As I was saying, during the time that the patient has this internal radiation, they are emitting radioactivity. There will be very specific policies on how much time that you limit being near the patient that's being treated. They will be kept in a special care area where there is shielding, lead line shielding that is available that kind of helps protect the caregivers that are coming in and out of that room to provide care to the patient. Sometimes they do have to lie flat for some types of internal radioactivity, and so they may need care and things done with them because they can't get up and down. Staff are always expected to have to wear a specific kind of film badge that monitors their exposure. And as you can imagine, caregivers, if they're pregnant or have certain healthcare conditions themselves, may not be able to provide care to patients when they're receiving this. And so it's always important to let other staff know if you do have a patient and you're able to go in the room, but you have a coworker that needs to know that information so that if they're not a candidate or not appropriate to go in there, and that may be true for other people too, like family members and other departmental people that might come through the department. Some of the common side effects of chemotherapy and radiation, bone marrow suppression that we're going to talk a little bit more about in class this week, fatigue that I've already mentioned, GI disturbances. I think many people are aware that lots and lots of chemotherapies cause severe nausea and vomiting, and so much so that even someone walking in a room with perfume may set them off. So most oncology units or clinics do not allow personnel to wear any kinds of lotion or scented perfumes and things because something simple like that can be just enough to set off those GI disturbances. I think we've already talked a little bit about some of the skin issues that patients can have. Of course, from radiation, they can have very reddened, irritated, painful skin for exterior radiation. They can have skin issues also from chemotherapy, and particularly mucosal reactions in the mouth where they get very irritated lesions coming from the chemotherapy itself, because the tongue and the mouth has got so much blood vessels that's close to the surface. So if they're getting lots of those meds through their IV system, they tend to kind of go towards the mouth because of all the blood vessels there. And then that creates a lot of tissue and cell irritations in that area. And people may lose their ability to taste because of that somewhat as well. We may see pulmonary effects. They're getting a lot of IV fluid sometimes over a short period of time. Not every patient can tolerate, as we've talked about, a lot of fluids going in them in a quick manner. You think about the people who have some atherosclerosis problems and then they develop cancer. It may be something that with all those fluids might put them into heart failure and things. And then there are reproductive effects to both radiation and chemotherapy, and that's good questions that patients need to consider if they're of childbearing age. Sometimes before they start these treatments, they can go ahead and retrieve eggs or embryo or donate sperm to keep available for later reproductive conditions that they would like to affect, but may not be able to following chemotherapy if they don't do it in advance. With bone marrow suppression, some of the myelosuppression is one of the most common side effects of chemotherapy, and what happens is you get treatment, and then in terms of it being in your bloodstream, the chemotherapy is killing off blood cells, both red blood cells and white blood cells, and it gets into the bone marrow through the circulation and may suppress the bone marrow from making new ones. And it does take a little bit of time, the lifespan of the blood cell, to kind of regenerate after that. So usually white blood cells take about 1 to 2 weeks, platelets 2 to 3 weeks, and red blood cells are usually starting to improve after about 3 weeks. And it's just based on how quickly that red blood cells and white blood cells and platelets are made in the bone marrow after the cellular death occurs. Neutropenia, which we'll mention in class, is one of the most common occurrences for patients who receive chemotherapy. But these changes in blood vessels can make somebody at high risk for infection. It can make them more at risk for hemorrhage because of decreased platelets. And in general, because your red blood cells carry oxygen through your body, you can get extremely hypoxic sometimes and have overwhelming fatigue from this. Patients report fatigue 70 to 100% of the time. And then it's really important to identify when the patient is beginning to feel better and may allow for more activity. We always encourage these patients to really rest before they do an activity, to get assistance with activities until some of this rebound has occurred, and then to really maintain good nutritional and hydrational status. And as you can imagine, with GI distress and lots of nausea and vomiting, patients can really get dehydrated very quick, as well as lose a lot of weight because of not feeling like eating for a variety of reasons. And some of this continues even a long time after treatments. So it's just, you really want to really closely watch their fatigue and their nutrition during this time period. Again, here's some of the talks about GI effects. Nearly every treatment is going to be given a prophylactic medication for antiemetics. We're going to watch them again for hydration status, their intake and output, and they should be on a very non-irritating, low-fiber, but a high-calorie, high-protein diet to kind of get the best amount of calories and proteins they can get in there without creating a lot of GI distress. And again, vomiting can occur within an hour of chemotherapy and can go on for several hours and days even after a treatment. Some patients also have to be on antidiarrheal medicines. Some of them have to be on medications that slow the motility of the GI system, or antispasm medications, because they may also, in addition to everything else, get severe diarrhea. We need to watch their weight loss and have them weigh themselves twice weekly just to kind of stay on top of that. And in many cases, a lot of these patients will be ordered on nutritional supplements like Ensure, or just extra things that they might find more palatable to eat or drink versus some of the foods, because sometimes liquids are easier to manage. We also want to teach these patients to really examine their oral cavity. Many nursing units that have this type of care will actually have an assessment in the computer system that is specific for grading the oral condition. We want to make sure that they're getting good oral care routine. And if they're going to have chemotherapy, you always want them to go ahead and get any dental work done before initiation. You know, we've found a lot of times with dental work, like when we studied endocarditis, patients that have frequent dental work or have lots of it are getting a high exposure for the potential for infections that way. And because chemotherapy is going to put them in a situation where they potentially are neutropenic, you definitely want any and all dental work done before any type of chemotherapy treatment is initiated. And then they usually should be good, for half a year or something and not have to have anything until after the conclusion of that treatment cycle. They may have serious problems with taste loss or trouble swallowing too because of the mouth issues and the attack kind of to the mucosa of the mouth. And so often it's really hard to get people motivated to eat because of the GI symptoms, but also because their mouth may be so very sore they just can't stand it, and they won't eat because it hurts so bad. So sometimes the doctors are going to order some swish and spit or swish and swallow type of medications that will have actually a numbing medication in it called viscous lidocaine. And it's just like you think about lidocaine that numbs the skin, or Novocaine when you go to the dentist. It's the same kind of principle, and literally they will take and swish and do this kind of thing for their mouth, and it numbs some of it, and it may be done right before meals so that they can kind of do that and have enough numbing capability to get some food in. Again, if dry skin is very, very common, you want to try to use non-irritating lotion or a solution that doesn't contain metal, alcohol, perfume, or additives. Again, the smells get to people. Alcohol itself can have a very drying and burning to irritated skin, so those should be avoided. And sometimes patients will have a very, what they call a wet reaction, where their skin on the outside just becomes very damp and painful and sort of galled, and it puts them in a situation that's at high risk for infection. So you may have some of those type of areas on the skin that require, some special dressings and things to really be kept clean and protected from further damage and for risk of infection through those sites. You want to try to facilitate wound healing for those. These patients need to keep their skin protected from temperature extremes. Many of them may be on chemotherapy agents that don't allow them to be even in sunlight, because it may create an excess burning to their skin that's even more than what it would be for a normal person. They do also talk about avoiding constricting garments, any other harsh chemicals or deodorants that can be harsh on the skin. And then they want us to really help patients deal with alopecia, which is their hair loss that comes with, and they will lose hair loss not just on their scalp, but their eyelashes, their eyebrows, and any other parts of their body that have hair may become hairless. And while it doesn't seem like it's as big a deal for a lot of people, everybody's different. You have to kind of work with the patient on what they feel comfortable with. Some people want to wear a wig to look more natural. Some people think the wig looks so unlike their own hair, or it's too hot, or it doesn't fit right, and it just makes me feel worse. Some people are very comfortable with going with a bald head through the whole process, and some others just want something easy that's comfortable to kind of wear as a cap on their head. And so until people try that, it's hard to know what each is going to work with. So trying to get them to kind of explore some of this, to educate them about some of it and explore kind of what they want to do. Some patients have found that it gave them a lot of courage and ownership, and felt better when they went and actually cut all their hair off themselves, because then it was their doing, not the drug doing it. So just some things to think about of how people cope with that kind of thing.